All right, I think we're getting ready to go here. We're waiting just a couple more minutes. Everyone's kind of getting in from work, and so everyone's logging in. So we're just going to give just a second just to make sure we get going.
Everybody gets on.
That's right. That's right. Okay, well, while everyone is logging on, welcome everyone. Thanks for joining us tonight. I'm Lisa Hunsicker. I'm a board plastic surgeon in Denver, Colorado, and we're going to be talking tonight about the Allergan Textured Implant recall. One of the things I want to do when we're doing this talk, we actually have quite a bit of things to be covering. We're going to go through all of the topics that we want to talk about, and then we're going to open it up for questions. And so I'm going to ask everyone during the talk just to make sure that on your end, make sure that your computers are on mute, because sometimes we get kids and dogs and cars and all kinds of extra background noise. That way everyone can hear us really well. But then once we go to Q&A, please feel free to open it up so that we can talk with you, and certainly you can type in as well. Lou from our office is here with us, and so she's helping out, and so she may be able to pick up some of the questions as well. So I hope you enjoy this, and please, if there's any questions afterwards, always feel free to give us a call and certainly come in and make an appointment. So Lou, are we ready to get started?
Yeah, we're good to go.
Okay, great. So again, I'm Lisa Hunsicker. I am a board certified plastic surgeon at Ravala Plastic Surgery here in Littleton, Colorado.
And I'm Dr. Roxy Guy, and I'm from Melbourne, Florida. And we just happen to be together sharing some information. So I'm happy to participate in this webinar.
So Roxy and I want to give some information, some basic information about anaplastic large cell lymphoma. And one of the things is it's such a rare entity that honestly all of us are still learning quite a bit about this. And so one of the things that many of you have heard me talk about is this is really a diagnosis that we're learning a lot about, and it's been very slowly changing over the years because there's so few cases that we learn very, very little about in little tidbits. As you all know, the FDA met in March and they reviewed all of the implant information. They then met in May and had their own report and disclosure. And basically at that time, they really didn't recommend that we do anything. Shortly thereafter, we had Allergan was notified, and now the death rate, which we had been aware was approximately 17 cases worldwide, was then moved up to 33. And so Allergan was then asked to basically halt sales. And Roxy, what do you think? I think recall is
that makes it sound like these implants are recalled and they need to be removed. And that's absolutely not the case. It just simply means the FDA asked them to take those implants off the market, take back the implants that were in people's offices so that they no longer get implanted.
And the implants that they really were talking about were the Allergan BioCell textured devices. And so this includes textured round implants, textured anatomic implants, and also tissue expanders. And
it includes saline and silicone textured implants.
Exactly. And so it's not the contents inside of the implants that the concern is, it's actually just the outer coating. And so
for the most part, women who have smooth implants really don't have to worry. And we'll kind of get into that area a little more granular as we discuss this.
So we wanted to do this webinar for you all so that we could get the latest information that has been released. Now, interestingly, speaking of latest information, if you go on to ravala.com, I've just posted right before our webinar that there's a new article in the Aesthetic Surgery Journal that basically is discussing how to address all of the surgical concerns for patients who are asymptomatic. So feel free to log on and check that out. It's a direct link to the journal so that you can pull up that article so you can see basically the same thing that we're seeing real time as for the recommendations. So Roxy, let's talk about ALCL.
And what is ALCL? And we're specifically talking tonight about breast implant associated ALCL, or anaplastic large cell lymphoma. So it's just more recently been discovered that there is a type of lymphoma, a cancer, that can be related very, very rarely to textured implants. It's not a breast cancer. It's not a cancer that's in the breast tissue, but seems to be around the implant itself.
And we've seen ALCL before, but it wasn't implant associated. So there are patients out there who have systemic ALCL. And by the way, ALCL stands for anaplastic large cell lymphoma. So that way you know which lymphoma that this particular type of cancer is. But we've seen, about 1,400 cases annually that are systemic, that aren't related to implants at all.
And whereas the ones that are related to implants worldwide, they've found only 573 cases in the entire world. So it's a different animal. It's not the lymphoma that can go throughout the body. It seems to be a gentler kind of disease.
I think the great thing about that is this is such an easily treatable condition that, it's very rare, but gosh, if you end up with something like this, it's very easy to treat.
And the reason that we're trying to get this information out is we don't want people to panic. That word recall has put a lot of people into a tizzy, and so we want to tell you about the treatment so that you understand that there is no reason for alarm.
Right, and so the current statistics, like Roxy said, 573 cases worldwide. In the U.S., we're about 228 cases. That number has been fluctuating simply because we have a couple of registries. We have the FDA and the MOD study, as well as the profile, which is through the Plastic Surgery Foundation, and MD Anderson is help coordinating with that. And so as each case comes up, it needs to be verified, and we need to make sure that it is truly a breast implant ALCL versus a systemic ALCL, which are completely different entities. And we know that these are actually in dental implants and orthopedic implants as well. So extremely rare in those instances in those patients as well. Worldwide, like I said, 17 deaths that we saw before, 13 now in the US. Those numbers changed in the last couple of weeks to 33 worldwide, which is what prompted the FDA to really pull those implants out of the marketplace, to really look at it and begin more safety data analysis to determine really what's going on.
And that's over 20 years since the textured implants have been on the market. So what we found so far, and realizing that practitioners are starting to be more astute about looking for this disease, for 20 years we found in the United States 200 and some cases. So it is a very, very rare disease.
I think the big key that we really want to put out to all of our patients is that if you have an issue or concern with your breast, you need to come talk to us. And I think what a lot of folks do is they're in seeing their OB-GYN, they're in seeing their primary care for their annual visits, and they don't really know. The primary care folks aren't as experienced with this as we are. And so one of the things I really want to make sure everyone knows is you need to call us and you need to talk to the experts in this. And most of the time, it's really not anything that you have to worry about. However, if it is, you want to make sure that you have a board-certified plastic surgeon who has experience in this so that you get the treatment that you need as right away, right, but also get the screening that you need, because you may not have that. And
That's
so
right.
You want to make sure that you have the right treatment.
And so if you're having absolutely no problems with your implants and you're asymptomatic, what we call asymptomatic, you're not having swelling, you don't have a lump, your mammograms are negative, you're soft and the implant is movable, there's really no reason for alarm. In fact, you don't really have to have an evaluation by your plastic surgeon unless you just want to, feel better about it. It's people who have some symptoms that we really want to have call in and get checked. And so we should tell them what the symptoms are.
I think that's great. I think one of the things that you have to be the primary diagnoser for this, because you know your breast more thoroughly than anyone. And so the things that we're looking for, seroma, I would say, is in the number one thing. And so what that means is that's a fluid collection around the implant.
So your breast starts to get bigger and you don't know why. You haven't hit it, there's been no trauma, and all of a sudden one side is bigger than the other, usually relatively significantly, or you might actually feel fluid around the breast.
Sometimes it has a sloshy sensation, almost even a waterbed, depending on how full it is. And we're not talking little tiny bits. We're talking large amounts of fluid. And in some cases, that breast can be 2 to 3 times the
bigger,
other side.
Yeah, at least a cup full. Mm-hmm. Yes.
Exactly. So seroma is number one. The next thing would be a delayed capsular contracture. And that's something that, usually once we have surgery done and completed, really within a year, if you're going to have a capsular contracture. And so if you're years out, which is really ALCL, the average time to diagnosis and presentation is 9 years. So we're talking many, many years later.
9 years after you've had your implants put in, that's when people are starting to see that occur, although it is very, very rare. And that capsular contracture is the most common complication with breast augmentation surgery. So if you have capsular contracture, that certainly doesn't mean that you have ALCL, but it's just one of those symptoms that you might want to be concerned about and therefore see your practitioner for.
Exactly. So we've got seroma, we've got capsular contracture. The other thing is mass. And so anytime anyone has a breast mass that they feel, we need to have that checked out. But really, we're seeing about 40% of women with ALCL presenting with a mass, and with the more later diagnosed with even higher, approaching 60%. So really, we want to make sure that all of these patients are examining their breasts, getting imaging. We want to look at it with ultrasound, but the recommendation with the FDA with silicone implants for sure is, you need to have an MRI so that way we can see all the way around the implant. And if you do have saline implants, but you do have a texture, I still think it's a good idea to image with MRI so that way we can see all of the tissue in front of the implant, but specifically, more importantly, behind the implant where you may not be able to feel it.
And most people will come in if they feel a mass or they feel a lump in their breast, regardless, because it could be several different things. So this is just one of the things that can alert you to this sort of a disease. And if you're not ready for an MRI, we can do sonograms. There are different tests that can be done initially. And so you simply speak to your physician about that and have an evaluation and have an honest talk about what should I do and how serious is this for me specifically.
Now, the other thing is rashes, and this I think is one of the hardest things. It's about 2% of cases have rashes on the breast. And gosh, Roxy, how many patients have you seen that have had breast rashes?
Many, right.
And,
yeah.
We all have them, and there's all different conditions, and there's yeast, and there's bug bites.
That's right. And maybe your soap you're allergic to, or you've used a new detergent. So that's not cause for, a terrible alarm either. But if you have a rash that hangs around and it really doesn't go away with like triamcinolone or cortisone treatment, yeah, you might want to look into that as well. And you have a textured implant.
Exactly. You want to really pay attention if you have a textured implant that this may be something that we need to look further. And maybe if you have this rash that doesn't go away, what do you think about doing a little skin biopsy? I think that's easy enough to do in the clinic.
Right. Yeah. Right. Just take a little tiny piece of tissue.
Yeah, and this doesn't have to be a big surgical procedure with ORs or anything. You just take a little tiny bit under local.
And not a big scar.
Right.
Nothing to be terribly concerned about.
Right. And again, those numbers are so incredibly rare. It's 2% of patients with that. And so I think if you're seeing that, you're likely seeing a big seroma at the same time.
Probably seeing a big seroma. So if you think about it, if you have a textured implant and you don't have symptoms, there's no cause for alarm. If you do have symptoms, then you should see your doctor. But your chance of having a problem is anywhere between 1 and 2,200 cases and 1 and 86,000 cases. So it's really very, very rare, and I can't emphasize that enough. We want you to be aware of it, but we don't want you to be panicked by it.
So when we talk about those numbers, if you have an Allergan BioCell implant, like Roxy was saying, 1 in 2,200. And so that's 0.05%. So it's not even 1%. It's less than that, 0.05%. And then if you have a Mentor implant that has a Siltex coating on the outside, 1 in 86,000. So 0.001. So we're getting even more remote.
Yeah, very remote.
Now, for those of you who do have Sientra, this is an interesting thing. We don't have any good numbers, but Sientra has pretty much fallen in line, very similar to the Mentor implants, but the FDA hasn't given specific numbers as acutely as Mentor, and Sientra is a little bit newer on the market, and so the number of cases are obviously going to be very different for Sientra. But thus far, I would tell you, if you do have a Sientra implant, we're going to basically follow what the FDA is recommending for Mentor implants at that point. But all of the implant companies have had, you know, a case of this. But again, when we're looking at this worldwide, gosh, Roxy, how many implants are put in just in the U.S. alone?
Yeah, there are, what, 500,000?
Half a million
per year. So there are a lot of implants, and very, very rarely does this happen.
Yeah, so if we think, let's say 20 years, so we've got 20 years of textured implants at 500,000, so that's 10 million women with implants. And, you know, for us, when we look at the textured market here, it's maybe about 12%,
something like that, right?
But worldwide, once you step outside the US, it's over 90%. And so the thing that I feel is that, gosh, most of the world actually has textured implants, and so we're still not seeing
that's right.
a tremendous spike, and we would actually expect it to be much bigger outside the US just due to the numbers and the percentages perhaps. So
it's the Allergan implants that are the ones that the FDA has asked to no longer distribute. So particularly if you have an Allergan implant, you want to be on with it, which is textured, you want to be on the alert. To date, there has not been a proven ALCL that's been verified with a smooth implant. So those of you who had smooth implants, primarily meaning you've only had a smooth implant, you didn't ever have a textured implant like with previous surgeries or something, then you can pretty much relax.
Now the other group that's kind of the in-between zone too is tissue expander patients.
Right.
You know, what about them?
And tissue expanders most of them now are textured because that just works so much better. And there has not been a reported case of an ALCL in someone who had a tissue expander and then ended up having a smooth implant reconstruction. So we haven't seen that.
So for those folks, I would say the majority of folks in the US probably fall into that category. We do a lot of direct implant, and so all of you ladies know us in our practice very well. So many of you may not even consider worried about tissue expanders because you never even had that.
Even have one, right.
But there are some patients who have, and certainly the thing we want you to know, we're actually recording this webinar so you can post this on your sites, or if you have friends who've had textured implants or tissue expanders, feel free to share this so that they are aware about what their risk is and probably is not. So what's Allergan's take on this?
Well, I know that the FDA suggested that they take them off the market, which they did. And so now they have decided that if a person wants to have their implant removed, I think that's right.
That's right.
Then they will give you replacement implants.
So the implants that you're going to choose, we have 24 months basically. What they have said is 2 years from the pull off the market. From that date for 2 years, we basically are eligible. All of our patients who have a textured device, if they want to have those implants removed, then they're going to give them a free pair.
But those patients will need to pay for the actual surgery, the operating room, the recovery room, the surgeon's fee, and so forth. And don't forget, this is a very, very rare disease, and there is some possibility of complications from the surgery itself. So you want to weigh the risk versus benefit of actually taking out an implant that may be perfectly fine, especially if you're having absolutely no symptoms. So, you know, in general, people who don't have symptoms, we really don't recommend that you have them removed.
Yeah, this, I think, is a very slippery slope where you're trying to figure out what's the best outcome for me as a patient.
Right.
How much is this going to cost me? Is it going to cost me? And how much is Allergan going to participate in helping us? I think that we have two groups of women here because I think we have augmentation patients or anyone who's had a breast lift or reduction and also had an implant where insurance is not covering this. And so many have asked me, well, what's the ballpark price? And so, you know, it's going to vary from region and even in each state. Cities and suburbs.
Each community.
Exactly.
But we can give you a ballpark.
Yeah, ballpark is maybe if you're just doing an implant exchange. Now remember, Allergan is giving you your implants, so that's not a cost you're going to have to cover. But basically, about an hour of surgery time, so that's OR, anesthesia, and surgeon's fees are going to be about $6,000, and again, some variability.
Yeah, and I'm in Florida, you're in Colorado, and I would say that where I practice in Florida, Melbourne, Florida, that's probably about the same cost.
Right. So now the next question is, well, what about capsulectomy? And do we do a capsulectomy? Do we not do a capsulectomy? What's the cost of that? Well, since we're talking about cost, if you add a capsulectomy, the time is going to change because that's a lot more work to be able to get that out.
And let's let them know what a capsulectomy is. Now, I want it to be perfectly clear that when you put an implant in, if you just like putting any foreign body in, the body's going to say, oh, you're not me, and it walls it off with scar tissue. And in the case of breast implants, we call that scar tissue the capsule. And there are a lot of things that we as surgeons can do with the capsule. Fortunately, if people don't have capsular contracture, that capsule is usually this very thin, very benign looking tissue that does not constrict the implant. So if we do a capsulectomy, that means we take away all of that tissue that surrounds the implant. And that's really hard to do if the capsule's normal, if it's thin and wispy. Whereas if you have capsular contracture, that capsule is thicker, it is starting to constrict around the implant. It's making the implants many times move upward on the chest wall and causing breast asymmetry. A little bit easier to remove the capsule in that instance. So the question is, if you're not having any problems, do we need to take that capsule out?
Right, and I think that's sort of the issue that we're really all trying to decide what's the best course here, because the thing is, you know, getting it out is sometimes very difficult. And it does come with some risks.
That's right. Sometimes that capsule is really, really adherent to the chest wall, and sometimes you can get into the chest wall, cause a pneumothorax. Sometimes it's very close to vessels, and it just because the risk is so low and the disease is so rare, it's probably not worth doing a total capsulectomy in a person who is asymptomatic.
Now, the other thing is that if you are considering the surgery to completely get rid of your risk of ALCL, we have seen cases where people have taken their implants out, or they've changed implants from texture to smooth, and they still have developed ALCL.
But that's what's the number for that? Very, very small.
Very, very
I think
rare.
In the teens, or less than 10, something
right,
like that.
Exactly. And so we have to really encourage you to really understand what your risk is and what your benefit is, and what are the chances of either one when we're making this decision? And there's no right or wrong answer for every single person, and we have to consider each person individually and what symptoms you may or may not have. And so really I encourage you all to consider all of this and then talk to a board certified plastic surgeon and make sure that you have all of your risks and all of your benefits.
So it's really nice to look at some of the information that you can find online through the American Society of Plastic Surgeons, on our websites, through the American Society for Aesthetic Plastic Surgery, and look at the numbers so that you can make a very logical decision. And it's so easy to get so worried about this because the word recall has come out. And we don't want you to panic because there really is no reason to panic. And also tell them about the treatment. If you really did have the disease, the treatment is a capsulectomy. And many times that's curable. You don't need a bunch of other things.
We see about 93% of patients who have ALCL at 3 years are doing fantastic and are disease-free. And so this is one of the great things about this process. It's a very slow, indolent process initially. When it does get going, you start to have symptoms, you want to move on this. But in many cases, people are being diagnosed very, very early. You could need chemo and radiation if you present with a much later stage, just like any other cancer. Your prognosis is directly related to your stage, but in many cases, these symptoms are so prominent that people are being diagnosed in stage 1, and so they just simply have a capsulectomy, have that implant removed, and you're cured, and you can have a new set of implants, and of course, it's recommended that you have a smooth device for that.
Right.
So,
but if you wait until you have a big mass, which nobody in this day and age should do, then it's probably going to be at a later stage, and then you may require more treatment.
Exactly. So chemotherapy and then radiation in these cases tends to be more for local control of chest wall involvement. Chemo seems to be at this point the mainstay of therapy. So if you're considering, this, what would you tell your patients time frame of if you want to see your doctor? Do you feel like you need to get in tomorrow, or?
Well, I don't think you need to go in at all if you have no symptoms. But if you're concerned, I want to get more information, I can't get my head around this thing, certainly go in. Right. And we're talking about people with textured implants. If you have symptoms, right away, come in, call. And the first symptoms usually are seroma, so you're going to know. You're going to have a breast that's much bigger on one side than it is on the other. And few people are going to ignore that, right?
Exactly, exactly. I mean, it's simply, you can't fit into your bra, and your clothes are very, very different. And it's not something that, you've gained. Maybe you've been on tamoxifen and you've gained some weight and your breasts are getting slightly larger. This is really in a matter of weeks having one side being significantly larger than the other.
And I don't think we have reports of bilaterality, do we?
No, not so far. Not so far.
So it's one side.
Yeah, typically you should expect to see it on one side. Now, if both sides are swelling, you should talk to us and let's figure out what's happening there. Certainly there's other causes that are related to that, and so we want to make sure, while it's not ALCL, you may need to have some other treatments to help with that too.
And just to put it in perspective, I have seen patients with seromas and have taken out the fluid, and they've been perfectly fine. They did not have the ALCL. And I personally, I've been in practice 35 years, I have not seen one case of ALCL. So again, I just want to emphasize that there's not a reason for panic.
Right. So we want you all to feel good about this as far as being educated, feeling knowledgeable, and knowing what your risk is, what your risk is not, and what your options are. So I think what we should do now, Roxy, you want to go to questions?
Yeah,
Shall
I think that's great. Yeah.
Lou, are we getting anything on written, or can we go to audio?
Or if there's anything that we said that was confusing, just ask us and we'll try to clear that up. Because I know it's a lot of information over a short amount of time and something that's brand new and everybody's trying to kind of wrap their head around.
Are we getting any questions?
Yeah, let's have them type in the box.
Okay, so everyone look on your box, and so there's a place where you can type questions in, and let's see if we've got anything coming in.
And for the most part, if people do not know what kind of an implant they have, you should contact your physician so you can find out if you in fact had a textured implant or a smooth implant. Sometimes it may no longer be in the chart, but there are other ways that we can find out what kind of implant you have.
Exactly. Remember that the hospital keeps records as well as the implant companies. For a long time, we've every time we go to the OR, we give you all an implant card, so you should have that as well. But if you have a device that's much, much older, maybe you haven't, then you can contact your hospital or surgery center where you've had the procedure done. In some cases, all of the implant companies have kept records too when device tracking has been done for patients, and so there may be information in the implant companies. And so you may not even know your implant company, but right now we have 3 in the US, Allergan, Sientra, and Mentor, and so you can talk with your doctor and we can see if we can contact the implant companies to find out information about that as well.
And don't forget, people with implants sometimes have had several surgeries, and perhaps you have a smooth implant right now, but you shouldn't just not worry about this if you have a smooth implant now, if you had a textured implant initially or at one of your surgeries. Sometimes people don't know this, so sometimes we try to track the different implants that have been inserted in a particular patient.
Right. We got some questions coming in. I have a patient asking, what about mastectomy patients? Risks for that, since you don't.
Right. So the question is how are the risks related to mastectomy patients? Interestingly, when we looked at the data at the deaths, actually, the breast cancer patients, reconstruction patients number was actually notably lower than the cosmetic patients. And my speculation about that is that your risk isn't really any different. So it's either you have a textured device or not. But don't you feel, Roxy, that all of the cancer patients are typically being seen and surveilled, and so they're getting MRIs, right. They're getting ultrasounds. You have all of us hovering
That's
on
right.
you.
Of course, you are very aware,
and you're much
very
more
breast aware. So that's a point in your favor. You're going to know if something weird has happened to your breast.
Exactly. And I would encourage all of our augmentation and our mastopexy reduction patients who have implants to be very vigilant about doing exams and staying up with your imaging. And honestly, feel free to come in and get exams. I know for our patients, I always offer our patients after augmentation. I'm happy, I follow you for a year, and then at that point, I'm happy to see you anytime for the rest of your life. Just come in, just call and come in. So if you have a textured implant, maybe consider coming in for an annual breast exam so that we can follow you, we can take a look, and if we see something, then perhaps we get more detailed imaging than the traditional mammogram. And honestly, what do you think about the young folks who have textured implants where they don't even qualify, because they're under 40, right. They don't have a family history of breast cancer, then perhaps they're not even getting any screening.
That's right. But most people of that age should at least see your OB-GYN once a year for a breast exam, pap smear, et cetera, et cetera. And so they should do an exam as well. And if they find anything that is not quite right, see if they can send you to your plastic surgeon. This information about this disease is being disseminated among all practitioners, but some are not quite as up to date as the plastic surgeons right now on this actual disease because it's so rare. So you can't count on other practitioners necessarily knowing about ALCL at breast implant associated ALCL at this time.
Right, and if you don't have a OB-GYN and you don't have a PCP that you're seeing regularly, feel free to call us and come in, and we can do a quick exam and we can figure out if there's anything that you need and be sure that you don't have any risk factors and symptoms. And it's a simple, quick check. So feel free to do that if you don't have those other options.
Right. If we find nothing and we don't think that you're time-wise you should have an MRI or a mammogram, then you might need nothing except just simply reassurance. It's okay. It's okay. If anything like seroma or mass or so forth comes up, then certainly see us.
But as far as risk, mastectomy patients aren't at any higher risk than any other patient.
That's right.
Okay, Lou.
Next question. If the patient becomes systematic, does insurance then cover the cost of implant replacement, etc.?
Well, that's a great question. So the question is, if a patient has symptoms, does insurance pay for it? I guess it really depends on what symptoms that you do have.
That's right. And it depends upon what the test results show. So, and I think that probably, in a way, the mastectomy patients might have a better chance of being covered by insurance because they have this history of disease and perhaps further treatment. The non-mastectomy patients don't know for sure. But if we do the required testing, and if by chance it's positive, then you fall into a different category, which is a patient with a tumor, and then insurance should pick it up.
So the testing, typically what we're going to see is if you have symptoms, the first thing we're going to do is an ultrasound because in many cases you've got fluid. And so we can draw a little bit of fluid off and send it to pathology, and they can run special tests and stains on that so that we can try and get as accurate a diagnosis as possible. Now, that being said, there are cases where there has been fluid present, large amounts of fluid, and that fluid tested negative, which I think was something that in the past we were so sure that if you had a large fluid collection and you tested it, it was going to be positive if you had ALCL. But there have been a few cases where they had a large fluid collection and tested negative, but they did have a capsular component, and so MRI imaging will help pick that up. Certainly, if any of that is positive, then a PET CT is our first and most important thing because that will stage us right away and will tell us exactly what we need to do. And the whole idea is to try and do PET CTs, especially if we do believe that you have ALCL and if we have fluid that's testing positive, we want to have that PET CT because
Absolutely.
we don't want to take everything apart and then try and test you afterwards. We want to get a good staging at that time to tell whether or not there's any lymph node involvement. In many cases, it's not, and so, but if there is, then we'll want to have a oncologic breast surgeon. For our patients, you know, Doctors Widener, Haffertepen, and Kircher, they would be involved in that as well. But again, that's very unusual that we do see that when we look at the numbers, but those are the tests that we're going to run.
Occasionally, I know of people that will do a small biopsy of the capsule and send that.
Exactly.
But that's not particularly definitive either. So there are some specific tests that we would run if we thought that you were at risk for that.
So we'll be looking for those symptoms and running those tests appropriately if you have that.
Right.
What else you got, Lou?
Do you expect the FDA recalls to include Mentor and Sientra implants?
That's a good question.
That's a great question.
Right. And right now, I think the answer is we don't know.
Yeah, we don't know what they're going to do with Mentor or Sientra. The numbers, like we said, you know, 1 in 86,000 is kind of what they're putting out for Mentor, and Sientra is going to probably tag on to that.
And what they hypothesize is, you know, not all textured implants are the same. There's some sort of smaller texturization, and then there's some texturization that they call a little bit thicker or more aggressive texturization. And so the different implant manufacturers have different ways that they have caused these implants to become textured. And so the association is more with the more aggressive kind of texturization. So still, I hate to cast any dispersion on a company because just because there's an association doesn't mean there's a causation. Did this texture cause this cancer? We don't know the answer to that.
Well, and frankly, at this point in time, we don't know the cause of ALCL at all.
That's correct.
We do know associations are related to perhaps biofilm, meaning bacteria contamination, a textured device, maybe time, because we know it's taking, you know, on average 9 years. And then maybe there is some sort of genetic predisposition that very much like BRCA gene patients, there may be a gene that some people are just more sensitive.
That's right. And we
don't know that.
who they are or what
Right.
the characteristics of that patient might be.
I would say that's one of the forefront of research right now, is looking at that information to see, is there patient characteristics and especially genetics that make these certain patients more susceptible, whereas almost nobody else has any issues. And very much like a BRCA gene, we have breast cancer. And so if you don't carry the BRCA gene, then you have, you know, the usual 1 in 8, but then some people do have this genetic predisposition, but all the rest of the people don't. And so again, that's an area that we're really trying to figure out.
It will be very difficult to figure that out because the numbers of the BIA, AC, ALCM is so low. Those numbers are so low. It's difficult to get numbers to give us significant ways to see if there is a relationship.
Well, and the thing, you know, we're looking at, you know, 200 plus cases here in the U.S. ever. And so, you know, you're trying to make a guideline and really understand a disease process. It's like, you know, looking not just for a needle in a haystack, but a needle in like a whole field.
Right, that's exactly
we're trying
right.
to find this.
And that's sort of the perspective that you should have about your risk. I'm a needle in a field of hay.
So, all right, what else have we got?
Are breast cancer survivors at a higher risk of getting ALCL?
No, and so the question was, are breast cancer survivors more at risk to ALCL than anyone else? No, and it's simply either you have a textured device or not. The question really, again, has to do with, is there a genetic predisposition that we don't know about? And that's going to remain to be seen, and that may take us, you know, many, many years to know that because the cases are so rare. But right now, our understanding is that they are no more increased risk than anyone else. What else?
We have a patient that wants to know, once you have the textured implant, the risk is always there, even if you opt out for removal and inserting a smooth implant.
Well, that's...
The risk is there, but it's 1 in 82,000 so far. That's the information we have so far. In those who do not have Allergan implants, it's 1 in 2,200 in those with Allergan implants. So it's still a low risk.
By those numbers, if you take that implant out and you put a smooth device in, that number is really hard to know. We have seen a few cases of it, but they're incredibly rare. The thing you have to think about is that, you know, remember that your texture is like a Velcro. And so you have the texture of the implant on one side, and then you have the capsule on the other, and you're removing one part of it, but we don't know what's happening in this. And again, the problem is we have so few patients that it's going to take us years to know, because we're just not seeing it. And so you have a 99.95% chance of never even experiencing it. So trying to find these needles in the hayfield patients in the first place, and then we're gonna have to follow them years, because remember, if, let's say everyone goes and removes them today, the average time is 9 years. So then the question is that 9 years starting from now? Is that starting from the original implant? And how long do we have to wait? And at what point do you call it and say, you know what, you were never going to get that in the first place?
Right. But there are people that are going to be anxious about this regardless of the statistics, the rarity, and so forth. So for those people who opt to have their implants removed, the question is, in order to really lower your risk as much as we possibly can, should we take the entire capsule out? Should we take all that covering around the implant? And we talked about this earlier. There's a very significant risk of doing that. So that's a big, long discussion that you have to have with your plastic surgeon.
Yeah, we want to make sure that you understand the risks of capsulectomy versus the risk of developing ALCL.
That's right.
Yeah.
Especially if you have absolutely no symptoms, breasts are fine, soft, movable, no capsular contraction, no seroma, no mass, and so forth.
What else?
So we have some patients that want to know an imaging schedule. So for breast cancer patients and for cosmetic patients.
Right. So the imaging schedule for our cancer patients. So many of you know you get to see me annually. And so I want to see you because I want to do an exam, but we are doing very particular imaging right now. The FDA recommends, and this is for all patients with silicone implants, that you start MRI imaging starting 3 years after surgery and then every other year thereafter. But in addition, if there's anything that we feel there's some swelling or there's a kind of a fullness or a lump or something changes, then that may include ultrasound. And actually, don't forget, all of the mastectomy patients, you may end up having mammogram. And so many of you have had fat grafting. And so there are little tiny masses that are left, which is just where little bits of the fat didn't survive. And that's called fat necrosis. And we see that in breast lift patients and breast reduction patients as well. And mammogram looks at that very, very well. So you're not going to be on a mammogram schedule, but if we see something, sometimes mammography, even though you don't have breast tissue, may help us look at that tissue a little bit better. Now, what do you tell your patients who are augmentation?
I tell them about the FDA recommendations, but then I also tell them if there's a question, come in and let's do an exam, and then let's talk about what imaging you may or may not have had previously, and then sort of mutually decide, should we go ahead with an ultrasound, a mammogram, or an MRI. At some point, I tell my patient, you really need to get a baseline MRI, and that should be within 3 to 5 years from your actual surgery. And then the follow-up MRIs, although it's recommended to be every 2 years, I think that the FDA is relaxing on that a little bit. So it's a discussion that you have with your plastic surgeon.
I think one of the very interesting things that I've seen, especially when we go to meetings, high resolution ultrasound is really starting to come into its own. And I've seen the radiologists using ultrasound more and more. And I think there's lots of development that's really happening. And I think in the past, I think ultrasound's been okay, but I think this really big push for high definition ultrasound has really kind of pushed forward. So I don't think it's there yet, but I think we're getting closer and closer. So I would imagine, what do you think? Probably in the next couple of years?
Oh, I sure hope so. And that should be a less expensive test. But as they develop the better techniques with the high resolution, we can't promise that either, right?
Right, exactly. Well, and so, for many of you, you've had mammography for many years, and now you've seen 3D tomography, which, wow, what a difference having the 3D and the computer and the high def component. Bonus to that, it's really kind of revolutionized what we're seeing. We're seeing so much more under mammography, and I feel like, the ultrasound technology is getting better.
It is.
So that's something to, another thing to stay up to date with your plastic surgeon, because then that way we can tell you, hey, now we don't need to do as many MRIs. Now the technology's gotten better, and so we can go ahead and do ultrasound.
Right.
All right. What else?
So we have a patient that wants to know if you develop signs or symptoms of the ALCL after the 2-year time that Allergan has given. Does Allergan have any, are they doing any costs associated with that after the 2 years? Have they noted that?
Yeah.
I don't think they'd answer that question.
Well, they, what they're telling us right now, their policy, and I think pretty much since this has really come out, I think that Mentor, Sientra, and Allergan all have financial assistance for ALCL patients. And so it just kind of depends on where you're falling. I've treated a patient already, and she did not have breast cancer before. She had had a cosmetic augmentation, and so she was financially taking care of everything herself. And those scenarios, all 3 of the manufacturers have discussed helping the patients out in different amounts. And so we'd have to see which manufacturer you've got and which program they're doing. And so there's a lot of help with that. With the insurance companies, interestingly, with our patient, while she had her augmentation as a cosmetic procedure, she now has a diagnosis of cancer, and her insurance really viewed it as, she has a cancer that needs to be taken care of, and so that was covered.
Appropriately, right.
Exactly. And so the insurance company, when you have that diagnosis, at least at this time, seem to be very supportive of this. And in my extensive experience of one,
and one, right.
and one, exactly. You know, that's what we're seeing now, certainly. And I tell you all this because everyone says, well, you know, is this going to be covered forever? I can tell you that at this time, in this moment, based on what everyone sees with the insurance companies, yes. But knowing that, you know, tomorrow is a new day and, you know, they could change their mind. I think the area that we have the most, you know, gray area is asymptomatic patients who have had breast cancer. They've had a mastectomy and reconstruction. They have no symptoms at all, and they want to do this as an elective exchange. That I can't tell you with any certainty because I think we are brand spanking new into this recall, and so we haven't really seen it.
That's right.
And so the issue I think that's at hand is that you need a CPT code, which is a diagnosis code, and right now there doesn't seem to have. We don't have a diagnosis code for possible.
Right. Or
ALC
rule out. We can't
exactly.
Rule. There aren't codes for rule out any longer.
And so, you know, I don't know, that could change in the future. They may look at this differently in the future. If you have other issues that are being addressed in your procedure, then I think that's going to be fine. But I think if you have a completely normal exam, you have no problems, you've otherwise been happy with your reconstruction and there's not been any issues, I think that's a wait and see, and I think we're going to have to take it on a case-by-case basis. And I would encourage you all to call your insurance company to see what their thoughts are. In our experience in this last week, we've had some patients call their insurance companies, and basically they have just said, well, have your provider call and try and authorize it and give us the codes. And so it's been kind of, it's like a punt.
Right, that's right. Code, no code, yeah.
You know, so I'm like, oh, well, as long as we have the codes, we're going to be fine, and we'll be happy to cover, except that right now there isn't a code.
We don't have a code.
So I think we're kind of in a gray zone right there. So we're going to take it step by step with each patient. So talk with us about that.
But I will say that the plastic surgery community is very, very diligently studying this, trying to get information as fast as they can, trying to disseminate it to insurance companies, other physicians, and so forth, so that we can all come to a consensus on how this should be treated, how it should be paid for, etc.
Right, exactly. And I want you to know that we have spent a lot of time investigating this and really trying to make sure that we have the most up-to-date information. So please, if you're not on our Facebook site or Instagram, please like us and join that community, because we do disseminate stuff. Sometimes it comes out, as many of you saw tonight, we had a new released article from the Aesthetic Journal that is really up to the minute. And so this is a way for us to get information to you right away, so you know what's going on. Of course, always feel free to call us, but
you can text us through our websites. Sometimes there's blogs on the websites with an update on this information.
Exactly, and we'll post this on our website as well. So stay, connected with us that way, and we can get you the information as quick as possible. But realize that this is not something as well studied as breast cancer, and many of you have had quite an extensive experience with breast cancer, and it's very planned out, and you have this, and we're going to do this, and then we're going to do this, and this is a brand new territory that we are exploring, and we're really understanding it. We're learning as we go. So
breast cancer has had many, many years of study. In regards to what is the best way to treat, we don't have many, many years of study in regards to breast implant associated ALCL.
And certainly the number of patients.
Yes, that's right. It's very difficult to study when you have a really small number.
Right. All right, what else, Lou?
Two more questions here.
All right, two more questions.
All right. What's the recovery time and restrictions for implant exchange? Patients would like to do that.
Well, I think that's, for all of you who've had surgery, it's way easier.
That's right. And again, are we just going to take the implant out and exchange it? That's really pretty straightforward. And you've already had, if you're subpectoral, you've already had the muscle lifted. You've already created a pocket for the implant, so there's not a lot of stretching and pulling. So if that's all that we do, take out the implant and put in a new one, that's pretty easy. You're going to feel good the next day. But if then we decide to do that total capsulectomy, then it's a little bit longer surgery. You may have a drain. You may have a little more pain and so forth. So it's that discussion again. It's not one size fits all. You have to be treated individually depending upon your circumstances and your degree of anxiety about the whole issue.
Well, and I think the other thing that people probably want to know about is time off from work. And I feel like with an implant exchange, gosh, it's so fast and easy. We go through the same incision, we exchange it out, don't need a drain. And so in many cases, people can be back to work, assuming you're not like lifting.
Yeah, you're not cleaning out the garage or running a marathon, please. Yeah.
Right.
Yeah, exactly.
But I feel like, if you have a desk job or something that's pretty low key where you're not lifting, I think you can be back to work in a day or so. In fact, I have patients, honestly, who leave because we're able to do this anesthetically, almost like a colonoscopy. So it's very light anesthesia. I've had patients who've gone out to breakfast afterwards. And so that's much easier. With a capsulectomy, it's a little bit more involved because you are pulling that lining out. The risk of bleeding is a little bit more. Drains are often used with that. And so maybe need to take a couple days off of work, but still, gosh, I would say is way easier than the original surgery.
And just bear in mind with a capsulectomy, we want you to be moving, but sedate for a good 2 weeks after the surgery.
Right, don't overdo. Yeah. You all who have been on my protocols know taking it easy. And I don't think, everyone's going to say, do I have to do T-Rex? And so, no, you don't need to do T-Rex, but you will need to be a little bit, I don't want you reaching up, because that area is raw. So, but you'll have a lot more freedom than you had from your mastectomy surgeries than this. So,
right.
Okay. What else?
All right, last question.
Last question. All right.
How long have textured implants been around for each company? Mentor, Sientra, and Allergan.
Oh, great question.
About 20 years.
20 years.
Except for Sientra, which is a relatively new company. They've been on the market, for 7 years, 10 years, something like that?
Right.
Yeah.
Right.
And I personally don't know how long did they come right out of the box with textured implants, Sientra?
Yeah, I don't know. I'd have to look at their distribution history. When they first came out, we weren't using them right away, so I don't know if they had a full portfolio that included smooth and textured. I imagine, and I believe that they originally started with smooth because the FDA has two different categories with smooth and textured, and the smooth devices, I think, were much easier to get
through the FDA approval process.
Get through the process. So I know that in the 410s, with Allergan, gosh, they've been out for a long, long time.
Right.
So, and we have, we've had textured devices for a long, long time. And so, like you said,
20 years, yeah, or more.
Mm-hmm.
Yeah.
Mm-hmm. Is that it?
Yeah, that's what we got.
Okay.
So hopefully this has helped answer a lot of your questions, help allay fears, and I'm sure there are fears out there, and we will certainly continue to follow this up and keep you informed.
Right, and I want to thank you all for taking your evening, because I know you all have families and work and hobbies and all kinds of other things, and probably hungry and want to get dinner. So we'll let you get back to your families and everything. If you have questions, if we've not answered any of your questions, please feel free to call us. Anytime you have any symptoms or issues, please call us right away. We want to see you. And for my patients especially, if I'm due to see you in a couple of months and you've got something going on, please don't wait. Call and come in right away. But again, if you have no symptoms, then we're on our usual schedule, and then I'll see you at your regular scheduled visit. And so thank you,
yes,
Roxy. Thank you for joining us.
Right.
And we'll see you next time. Take care.
Bye-bye.
Good night. Bye-bye.